Good morning to each and every one of you. My name is Skip Cimino, and I have the honor of being the president and the CEO of Robert Wood Johnson University Hospital here in Hamilton. You are in one of our facilities known as the Center for Health and Wellness. We started this facility back in 2004. We were almost prescient, if you will, about healthcare reform and prevention and wellness as we move forward here under the Affordable Care Act. This is a medically based fitness facility, so it's not merely a gym, if you will. It's medically based fitness. We have 3 therapeutic pools. We have a significant area of gym floor. We do physical therapy here. And in addition to that, we also run community education programs out of here with a medical advisory panel that shows many residents within our community such important things as how to deal with congestive heart failure, diabetes, as well as potential other chronic diseases and what have you. There are 8,500 members that belong here, so we are very proud to host this morning. My compliments to Rebecca Perkins as the president of the Council on State Public Affairs. Perhaps some of you have attended previous conferences. I know that I've had the opportunity to participate in previous conferences. The issues that are brought before this group today, as well as in other instances, are extraordinarily timely issues that are affecting, candidly affecting not only our state, but also affecting our national government, and will have impact on people for years to come. With that, I'd like to introduce Becky Perkins to open our conference. Becky.
Good morning. Welcome to our 3rd annual New Jersey State of Health, and let me begin by thanking Skip and all of the staff here at RWJ Wellness Center for their support for the event and for the fabulous facility. For many of you, like me, this is your first visit to the facility. This was my first experience with it. I was just amazed to find the conference facility that we have here. It's a really excellent facility, and it's the generous support of RWJ that really helps make this event possible. And I do want to acknowledge our other sponsors as well. New Jersey Manufacturers, NJM, is a longtime generous supporter of the council, and a new sponsor at this time, Slayback Health. And there's some information about them. Slayback Health specializes in telemedicine, an interesting new field that's very much impacted by ACA. So be sure and pick up their material and speak with them as they're here this morning. So it's, again, as I said, it's my pleasure to welcome you here. As you all know, if you're regular conference attendees, anytime you're close to Route 1, you get traffic issues and you have weather issues, and so we're dealing with that a little bit this morning. So I'm going to pinch hit a little bit as a moderator for the first panel, and fortunately my task is a lot easier because I have at least 2 of the most informed people in the state on the health insurance exchange. I think you'll find as we go through our panels this morning, we've been very fortunate in pulling together amazing panelists for this conference. The question that we really want to focus on is New Jersey ready for the ACA? So as we get very in-depth, I think, in some of these discussions about the exchange, about Medicaid expansion, about the impact that ACA will have on hospitals, that's the theme that we want to keep coming back to is how far along is New Jersey in terms of preparedness, and are we really ready for the impact? And these people, our panelists, are going to help us determine what that impact will be, and again, how ready we are. So if Chris will come up, we are actually going to get started. I'm going to switch over here, so we'll have just a minute for technical issues while I get mic'd up for this panel. But actually, while I'm getting mic'd, I'm going to kick it off to you guys and throw out an opening question to you both. And Governor, perhaps we can start with you. ACA is really landmark legislation. It's going to have a major impact on this country, you know, obviously for years, decades to come. So in general, what's your opinion of the Affordable Care Act? Good legislation? What's your opinion on that?
Well, first of all, I'm pleased to be here, and thank you for the opportunity to come and share some thoughts with you. This is obviously a very important issue. And healthcare is reported to be 18% of our gross domestic product, which means that roughly out of every $5 that we spend in this country on productivity, $1 goes to healthcare. That's a fairly large percentage of the amount of resources we have. I went to Congress a number of years ago. In the first couple of years I was in office, I served on the healthcare committee. And the congressman who was the chairman of the committee at that point was a fellow named Paul Rogers, congressman, very nice congressman from Florida. He used to say that our goal in healthcare is to strive to have a system that brings into balance access, quality, and cost. And he said that would be the perfect system if we can do that at perfect equilibrium, which lends itself to the old joke about the healthcare planner who died, went to heaven, got to talk with God and said, will we ever have such a plan? God said, yes, but not in my lifetime. I don't think you have to be quite that pessimistic in terms of moving in that direction. And the Affordable Health Care Act is an effort to try to move in the direction, bringing those three variables into collaboration. I guess my thought is that I think we're moving towards universal care, which I think is desirable. We've got 50 million people without health insurance at this time. This act purports to be able to provide insurance coverage for 30 million of those people. It sets us on a path to ultimately get universal care, which is the goal. Likewise, I think quality, things that are happening in the bill that do move us in the direction of greater quality. There are a number of demonstration projects, the overall goal of trying to have data-driven outcomes as a reimbursement vehicle, rather than just quantity of services we provide. I guess my one apprehension is on the cost side, whether we really are doing enough to be able to get control over healthcare costs. I'm a little skeptical, because I think essentially we still are going to retain the marketplace system. There are some forces that work separate and apart from the Affordable Care Act, which are moving in the direction of a high degree of consolidation. Consolidation results in much less competition. So the question is, we're moving a marketplace system, and we're having hospitals merge, we're having insurance companies merge, we're having doctors groups getting bigger, all in the name of coordination and consolidation. How does that work vis-a-vis competition? And in addition to horizontal integration, we're now having vertical integration. Hospitals acquiring insurance companies acquiring hospitals. So there's a built-in bias that seems to be anti-competitive. I'm not sure that that's what's going to result, but at least it's something we should be thinking about.
So we have our panel. And it sounds like, Governor, at least your preliminary thinking now is where this is the beginning. This is not the end. You know, healthcare is going to be on the national agenda forevermore.
I'm even comfortable in saying that within the next 5 or 6 years, you'll make another evaluation as to whether cost control is actually working in some respects. And if it's not, we'll go back for another bite of the apple. The next administration, whoever it is probably going to go back and say, well, maybe we have to tinker with this a little bit. What form that takes, I'm not sure. Public option, single payer, or something that is going to provide for much more control and costs that we have.
John, are you on mic?
I think so.
Okay. Professor Jacoby, tell us who are the uninsured in New Jersey, and how does the Patient Protection Affordable Care Act assist those uninsured getting insurance?
Well, the uninsured in New Jersey are mostly people associated with the workplace. They're in families, predominantly they're in families with workers, full-time or part-time workers, and the dependents of workers, whose earnings are too low for them to be able to certainly afford their own insurance, and whose cost share in employment-based work health insurance is too high for them to match it, or their workplace simply doesn't offer insurance. There's a smaller group of people who are not in the workplace or associated with the workplace who are not insured also. So the two pieces of the Affordable Care Act that are intended to address the insurance of those people, getting those people covered, are the raising of the Medicaid rate that will capture low-income people, mostly people below 138% of the poverty level, and the subsidies offered through the exchanges, or the exchange, which will allow people with low income but above 138% of the federal poverty level to purchase insurance. So this has long been the theory of expansion of coverage to pull up the Medicaid system and pull down the employment-based system and the private system, and that's in structure what the Affordable Care Act attempts to do.
So I know there's another panel that will follow us to talk specifically about the Medicaid expansion. So, but between the Medicaid expansion in New Jersey and now what we're calling the subsidized private health care, do you have an estimate on how many New Jerseyans will be covered?
Well, I see several people in the audience who could give a better estimate of that number. I think that there will certainly be hundreds of thousands of people covered. I think that there are several barriers to getting those people covered. One is the information deficit. That the people who are uninsured are typically very busy people trying to, they're struggling to make their rent, to put food on the table, and they're not paying attention to conferences like this. They're not engaged in the rollout of the Affordable Care Act. So getting navigators and health educators and information out to those people is going to be very important. At the upper hopeful ends of the expansion of health insurance, I don't think are realistic, at least for the first couple of years. I think if we can start getting people enrolled in Medicaid who are newly eligible, reach those people who are eligible for Medicaid under the old system who never enrolled or were fallen off the system, and bring people into the exchange who have never been able to afford insurance. If we could add several 100,000 people to the insurance rolls in New Jersey in the next couple of years, we'd be doing a great job.
Assemblyman Conway, Dr. Conway.
Morning.
Welcome. The subtitle of our discussion here this morning is should it be failure to launch?
Well, one hopes, and it is difficult getting information, that that the federal administration, the federal government, and the state government are moving as quickly as they can to get all of the, particularly the technical aspects of operating operations in place. I've had meetings with folks working on getting, automating, if you will, the eligibility determinations that will need to be made to slot people in the right place depending on their income, or that would then let you know what subsidy level they might have depending on their income, or if they to get them in the Medicaid program. And I agree that one of the big challenges is this question of information, letting people know that there is going to be a process that will allow them to get insurance, a process that was not there and available to them before. And as I view the success of, people argue that word, I'll use the word success, of what has occurred in Massachusetts, one of the big components has been that they advertised. They spent, a good deal of their budget on advertising the presence of the exchange in Massachusetts, letting people know that it was available to them. And, we recently had a bill on the floor that would, require the government, as it touches people in our society, motor vehicle, labor department, what have you, that information will be provided as part of those communications, as part of the regular communications that the government may have with our citizens here, in order to raise awareness as sort of a low-cost way of raising awareness. But I think if we are not in print media, if there are not billboards inside of buses, if there's not advertisement at the River Sharks games or wherever people congregate, then I think we will fail. We will certainly slow down the uptake of people into the exchange. Had a meeting over the weekend in Denver with some folks from CMS, and put the question to them whether or not they are, what's their budget with respect to advertising. And I have to say I didn't get a very compelling answer from them that there's enough money that the federal government intends to place in the advertising bucket. That concerns me very much.
I'm going to get back to Professor Jacoby shortly on just to explain to the group what the exchange actually is. But Assemblyman, you of course authored the New Jersey Health Exchange Act. It passed the Assembly, it passed the Senate, and was vetoed by the governor.
I have to bring that history up.
And no, I'm just wondering.
We soldier on.
In terms of public policy, what was the argument favoring a federally run insurance exchange?
Well, and the governor's argument was that with the costs being less known than perhaps he would like and others in his administration would like, why not let the federal government do it and bear the costs? We'll get to the same place, but it'll be on the federal dime. And I can't say that that is a, that thinking is certainly reasonable. One of the concerns that many of us had was that the exchange ought to be tailored for our particular marketplace. Remember, the exchange is nothing but establishing a marketplace whereby people who currently do not have insurance can obtain it. And that's whether or not the government's going to take a proactive position as they're doing in California, where they're going to be an active purchaser and presumably drive a very hard bargain to drive down insurance rates, or not, as personally I think would be a good idea. Others obviously think that's not a very good idea. One thing that I think will impact the marketplace here and will have a positive benefit for consumers of insurance is that we are going to see a cooperative exchange in New Jersey in competition with the private insurers that should help to drive down costs for folks who need to be able to get affordable insurance. And for hospitals who are in this game providing care, whether or not anybody can pay for it, having folks that can now pay for the care, at least a portion of the care they get, will go a long way to helping to address the terrible sort of balanced payment system process that affects our hospitals. Too many of them operate in the red because they have to provide too much care that's uncompensated.
Just to reinforce that point, the importance of the cooperative as an alternative to the private insurance system. Many of the big insurance companies, United Healthcare, Humana, Aetna, have all announced that they're only going to take part in a limited number of exchanges. Presumably, they're going to take part in those areas where they dominate. So to the degree that we're concerned, and should be concerned, about some unofficial allocation of companies to different exchanges, that will not work in a very competitive way, because the dominant insurance carrier in the exchange will set the tone. So the non-profit cooperative may very well function as a public option and a measuring rod against which other insurance companies will be evaluated.
Mm-hmm.
Well, speaking about the market, and Professor Jacoby, you had done the research for the Rutgers Center for Health Studies, looking at various models of governance. And again, for the group, just so we understand, the purpose of the exchange is to create or manage a market so that individuals and small business can buy insurance? Is that the primary purpose of the exchange?
Yeah, that's right. Let me just pick up a couple of the threads from Governor Florio and Dr. Conway. I think that it is correct that the Affordable Care Act does little to control costs. And I think that was built on the work of the Massachusetts exchange, which was avowedly intended to cover people for human reasons, with the agreement that as time went on, costs would be addressed, and that is what Massachusetts has turned itself to now. So I think that we should think about the Affordable Care Act as getting people covered. The second thing is that the big lift here, as Dr. Conway has suggested, and as I suggested earlier, is going to get people insured. Now let me get to what the exchanges are intended to do. They're intended to be a marketplace. In fact, the federal government is now calling the exchanges marketplaces. I wish we would stop changing labels on these things. But the notion is to simplify the ability of people who are now uninsured to locate suitable coverage and a connection between that coverage and an appropriate subsidy to allow them to have a card that will allow them to get care. It's a tremendously complicated system. It's a complicated system because of the compromises that were front-loaded into this. We have what we have because there was so little agreement on what would have been simpler systems. Governor suggested that we may have to come back to that. I think that may be true in 5 years or so. So how are we going to get this system up and running? It's going to be a marketplace in which the federal government is now testing the web portals and the paper application systems, which will be completed, they say, and I think that they're right. It's coming along remarkably smoothly from what I've been hearing in Washington. But by August, all of the online systems, the ability to check with IRS records and Homeland Security records and Social Security records, is all going to be integrated into the federal marketplace. People will go online or in paper, sign up for insurance. They will hopefully have the help of navigators and others to guide them to the proper system. And they will select insurance. They will be connected with subsidies, pay whatever premiums they owe, and get a health insurance card. It is coming along, I would say it's coming along apparently in a relatively smooth way because the people in Washington who are running it are quite pragmatic. It reminds me of what I read about the rollout of Social Security, of Medicare in 1965. A tremendously complicated system that was brought forward and made successful because a small number of very dedicated government officials in Washington spent years responding to problems that come up on a day-to-day basis and solving those. And that's what's happening in Washington. Unfortunately, what that has meant going forward, and just finish this thought before we move on. What that means going forward is that when tough decisions have to be made, they're often put off. For example, how will we determine what an adequate network is for a health insurance company under the Affordable Care Act? At this point, the explanation is somewhat sketchy. We'll clearly be borrowing from federal officials will be borrowing from state regulators on network adequacy. On essential health benefits, we're borrowing from state models. That means that the system that was unsatisfactory in 2009 is going, at least temporarily, to be too much of a template for what goes forward in 2014. But that's necessary in order to get things moving, and by getting things moving, what the focus is in Washington is getting people covered and getting them matched up with their subsidies.
I want to talk about the supply and demand and costs. Assemblyman, it seems to me that there's going to be an enormous new demand for healthcare services.
Oh yes, insurance will always drive that. People who have been delaying care, not getting care, who suddenly have an insurance card now want to, oh geez, I'm supposed to get all of these preventative health services. I have a doctor now, I have to go see them for this or that ails me. So you're going to see a tremendous uptick in demand as people get insurance.
No co-pays for preventive services,
And there
no
shouldn't be.
deductibles, no lifetime limits, no annual caps.
People shouldn't go bankrupt because they have health care needs, yeah.
So there are two components here, right? There's the patient protection, and then there's the affordable care component. But if you're an advocate for ensuring folks who have been left out of the system, this is a tremendous transformational law to give people health care in this state and across the country.
Well, it is, but it's a wall we're going to have to climb. You know, watching some of the reports and talking to folks from Massachusetts, you know, you did see that there were long waits getting to your doctor. The doctor that you had for years, because they were seeing new patients, might have had to go to weekend hours, bring in new associates to handle the load. But this is what always happens. There's nothing new. Healthcare is not, can't divorce itself or separate itself from the broader economic forces that drive any kind of economic system. And we'll see this in the healthcare place too. So there's going to be some undercapacity, and that capacity will increase as the demand setting increases, and it'll smooth itself out in time. But the argument that some have made that we shouldn't move in this direction because we're going to have this increased capacity, or rather not enough capacity in the near term, as I think is short-sighted. So, we'll get there. And, what the big challenges are nationally, in my view, is that we're going to be moving from a system, hopefully, if we can follow the model set in other countries who have much better healthcare outcomes than we do here in this country, is to begin to spend our resources in healthcare and primary care is the management of chronic disease. It drives 75 to 80% of the cost, and part of the reason why those costs are high because so many people don't get good preventive primary care in a medical home where their diseases that might affect them throughout the course of the lifespan are taken care of when it can have the most impact on improving and maintaining their life over the lifespan. We don't do that in this country. All of it is, I should say far too much of it is, care when a process has gone untreated for far too many years. So instead of diabetes is well controlled, you have limb loss, you have kidney failure, you have eye disease, ocular disease, heart attacks. And same thing for hypertension, same thing for our failure to manage obesity and all the costs associated with that. We need care and the dollars, therefore, to shift into primary care. That's going to be a hard fight because the folks, the specialists and others who are enjoying, God bless them, a very nice living providing specialty care, often care that comes too late in the lifespan, are going to be fighting to maintain those dollars. And how that gets worked out in Washington is going to be an interesting thing to see in the coming years.
Actually, there's another structural problem we have that adversely will affect costs. I mean, every sector has become much more capital intensive. Whatever the sector, energy, telecommunications, all looking for more capital. Healthcare industry is likewise looking for more capital, becoming much more capital intensive for technology, for electronic records, and things of that sort. Every other industry, though, that is looking for capital is paying in part for the capital by downsizing the workforce. So in the steel industry, we have productivity, but not as many workers. Automobile industry, we're more productive, doing well without workers. The healthcare industry is somewhat unique in that it's particularly labor intensive, and therefore you're not going to have the ability to trade off your capital costs with reduced workers. As a matter of fact, it even is compounded because we're now, as a nation, saying healthcare is the job-creating sector of the future. And you talk to mayors in the towns, they say, eggs and meds are going to be the new job creator. And therefore, you're going to be having more employees while you put more capital into the process, which is then not going to allow you to get the same reductions in costs that you get in every other sector.
Well, the key to cost, the key to cost is getting at this question of managing population health, managing conditions that one might potentially get early enough in the process to actually bend the cost curve. All this, the cost curve will not be bent until we do something about lifestyle, about the choices that people make. That's an educational process for our population. And I think of my daughter when she was in grade school. And now she has two physician parents, so she does have that going for her. But they had an education process on healthy eating, and she stopped eating French fries. And so you can have these interventions that can have an impact on someone's life. It's got to be comprehensive, certainly, but until we manage chronic disease, until we get primary preventive care out there broadly accessed by the population, do the educational process over one's life, appropriate relationship to activity and exercise, fighting insurance companies as we do to get them to pay for smoking cessation, to get them to pay for obesity care. I was at this conference this weekend. There was one of the best performing health insurance companies out in the West. They said one of the reasons they're so successful is because they pay for prevention. They understand that if you get a mother prenatal care, that you're not paying for a baby sitting in the NICU. That if you get someone to stop smoking, you're not paying for the heart attack or the vascular disease that leads to complicated care and limb loss. And when I think over the years of the number of pieces of legislation I put in to get prevention, get the insurance companies to do prevention, almost universally opposed. Every time I brought these bills forward, and to see that in practice it works and saves money, all I can say is a shame that we don't have a more forward-going, prevention-minded healthcare, I should say health insurance system in this state.
A general question to the three panelists. The default option to a business group, business lobby, is that these mandates, if you want to call them that, are increased costs. So how do you, again, a question just to the group generally, you know, balancing the requirement for prevention, balancing the requirement that the essential coverages include the types of programs that you're talking about, balancing that out against the cost. Because when you talk to the business side of it, they're going to say that it's the mandates in part that have really increased the costs on the employer in New Jersey and on consumers generally. I'll start with you, John, about balancing the mandate with leveling out the costs.
Well, I think it's a complicated topic because what we mean by mandate it depends on what part of the healthcare system you're looking at. In New Jersey, we mandate that health insurance cover hospitalization. I don't think anybody thinks that there's something wrong with that. On the other hand, at the other end of the spectrum, there are aspects of mandated care that clearly have been generated by profit-seeking entrepreneurial actors in the
I
healthcare
want
delivery
my
system.
product, I want my service, I want my device, I want my whatever I am making or selling or providing, I want that to be on the list of essential.
That's right. And the reason that there's this conflict between the impulse to get people the care that they need and the distortion that arises from this sort of rent-seeking from entrepreneurial actors is the way that we have historically paid for healthcare. It creates a disconnect between our goals and our means. And one of the good things about the Affordable Care Act that will take some time to play out is health systems reform. The governor was talking about this when I so rudely came in late, but one of the things that the Affordable Care Act tries to further is a pre-existing movement in the healthcare delivery system in the United States that attempts to aggregate the forces that provide care for people and place the onus for appropriately distributing resources on healthcare provider systems. So if accountable care organizations, for example, work as they're supposed to work, and as they have worked in mature systems which, unlike New Jersey, have involved the partnership and collaboration of healthcare providers over the last couple of decades, we may get to the point where the question of whether you have to mandate a service because some health policy person or someone in the legislature or someone in the executive branch thinks that adding this piece to the system will help patients, that dynamic will go away because the people who are responsible for the care for the entire person and for the entire community will have the ability to pick and choose the appropriate modalities of care from the armamentarium that they have with them.
See, that's the rub, isn't it?
That sounds amazing.
It does. And one of the things that you know, every mandate, if you want to call it a mandate, is something which has to be evaluated in terms of its cost. Now, a few years ago, we had a battle over mental health. We just passed another bill through my committee today, which hopefully will get on the governor's desk, be interested to see who signs it, on mental health parity. And I have, for years, opposed this idea that you can sort of segment someone's life. Mind, body. People have psychological or mental illness that can be treated. We know that there are costs to untreated mental health in this country. We know what burden it places on our healthcare system. Why should that be treated differently from physical illness? You want to call that a mandate? I'm happy to say it's a mandate. I'm trying to get the whole person treated, and that includes issues involving mental health as well as their physical health. Now, are there, Mr. Jacoby, Professor, I wondered about the mandated services and procedures, and I was trying to think of an example where that existed in the mandate structure we put through the legislature. We have not done bills, for instance, that would say that you have to do a particular procedure. We have said that you need to do preventive care. We need to prevent women from being discharged prematurely from the hospital. Now, if you have a quality measure that will allow some flexibility there to make sure women and babies are protected leaving the hospital, maybe you don't need to have a mandate. And that's where accountability over time may be very helpful because people are going to be held accountable for these kinds of decisions. My concern is that we've seen a lot of decision making that might be good for one's bottom line because people don't have to pay the costs of those decisions. The individual bears it, The family bears who now can't pay their bills, or the family bears that when their health care needs go unmet and their lifespan is short or the quality of life is decreased. So this question of a mandate, these costs, to me, are often result from an analysis that is short-sighted, looking to the next term, to the next enrollment cycle, rather than over the long term.
Well, can I just respond to that just for 1 second? So don't get me wrong. I'm not saying that what the legislature does when it creates a mandate is necessarily incorrect. I'm saying it is an unfortunate byproduct of the way our healthcare finance system works. We don't have a healthcare delivery system to save money. We have a healthcare delivery system to get care to people. We should be doing it in as parsimonious a way as we can that is consistent with good health. When the healthcare finance system was and continues to be as screwy as it is, then the legislature has to step in and make its best judgment about what services should be mandated. What I meant was that as we move forward, I'm hoping that some of the incentives can be joined so that healthcare providers will have the proper incentives to pick and choose the right services. I'm sorry.
What we're really engaged in, and you're seeing a little bit here, is a philosophical debate as to what healthcare is. Is it a commodity, like an automobile or a TV? If you can afford it, you can have it. If you can't afford it, you're up the creek. Ours essentially is an employment-based system. And it's interesting because that means that we're rolling the cost of healthcare into the cost of the products we make, the service we make. And we're the only industrialized nation in the world that does it that way. Mm-hmm. So our people are at a competitive disadvantage when the car is out in the marketplace and the automobile industry in New Jersey says 10 to 12% of an American-made car represents healthcare costs to employees and retirees. And nobody else in the world has that disadvantage. So we're really discussing. I think the ACA moves us in the direction of saying it should be really not just a commodity, it should be almost an entitlement of citizenship, as every other nation in the world does. We're moving in that direction sooner rather than later.
Well, we're already later. Sooner, we blew way past sooner years ago.
But we have the governor who signed our New Jersey's healthcare reform law in 1992, I want to say. And when you compare the consumer protections and the patient protections, generally speaking, guaranteed issue, no pre-existing condition, it's very, very comparable to the Affordable Care Act. So we have an experience here. We have several decades of trying to balance providing coverage, increasing demand for coverage, not throwing sick people off health care plans, ensuring that they have adequate treatment. The result has been high percentages of coverages, but very high costs. I think we're second or third in the country.
Well, I think the Massachusetts experience that was referred to is illustrative. The fact that you use for coverage, certainty, access, some degree of quality, and then you'll get around to the cost. Again, if healthcare represents 20% of our gross domestic product, we've got to be fair to say that we've got to get some control over that, and hopefully the Affordable Care Act provides us with a number of demonstration projects to deal with hopefully quality as well as cost. So I'm cautiously optimistic. Just our patience is not great. We want to see things occur. It's just unrealistic to expect that in a short period of time you're going to be able to correct this thing that represents 20% of our whole economy, and you're going to do it in a very small period of time. It's going to take us at least 10 years before we get to the point where we have a system that hopefully we'll be proud of.
Well, is it 10 years that we have to hold our breath? And I can see that we're winding down. My concern is, yes, you're right, we'll get around the cost, but my concern is that in the meantime, employers particularly will pull out of the small group market, send their employees, direct their employees to the exchange, and then really putting that pool under great enough pressure.
Well, it depends on, as always, what kind of lives come to the exchange, and there is a concern about what the president of the exchange will do in the marketplace, and people who are working. The reason why people have somewhat better healthcare costs, lower costs when they're working, so they tend to be healthier. And the addition of people who have had a long history of employment and having insurance through employment going to the exchange shouldn't have, I think, that much of a negative impact on the exchange. The issue are those people who are long-term unemployed. If you look at that population, they tend to be less healthy because they tend to have less access with the healthcare system and have tremendous needs that have gone unmet for years, chronic conditions which have gone untreated for years. And that's where people get very afraid when those folks are going to be bought into a system now, because if you look at them as a class, they generally have poorer health. And that those things will, the experience rating, the experience of those people now in that market would be expected to have to drive cost. I did want to say that to congratulate the governor for his foresight, because one of the things that with the reforms that have been made on a national level is that we already have, I think as you pointed out, experience with a lot of these things already. The transition for us is going to be much less than it is for than it will be for states out in the Midwest, for instance, which don't have a lot of these consumer protections built under the law. I happen to think those protections are important, and we want to think as a community about the cost impacts on a senior citizen versus a young person. Young people are going to have to be encouraged. One of the keys, I think, going forward is giving incentives for young people to get into the exchange. And one of the things that someone mentioned this past weekend, if you look at the Medicare Part D, every year you delay and joining that system, you pay a higher cost. Now, wouldn't it be interesting if that kind of thing were implied, or that kind of process had something to do with the incentives for a young person getting insurance? So the longer you go without insurance, sort of roll the dice and drive your motorcycle and get in an accident, get in the hospital, and have everybody else pay for it. Perhaps your cost of entry should be greater because you have sort of been a free rider in the system for that period of time when you decided not to have insurance. Now, it's working for Medicare Part D, and of course people have needs in getting in the system and deciding, yeah, I better get into the system now because it's going to be lower cost over time. Perhaps we should think about that as an incentive for young folks who are going to be critical. Their involvement in the exchange is going to be critical to holding costs down. We need healthy lives who are not going to be using the system to hold down the costs for everybody else, particularly our seniors and others who have our chronic needs that need healing.
I think we're going to wind it down. I think we have a moment or two. The subtopic of the discussion is New Jersey ready. And John, I'll start with you, and just in a moment we'll just go through your take on whether we're ready for essentially open enrollment in October, and if not, what would you, where your poll, what would you like to see happen?
Well, I think that I should knock on something, but I think that the federal government will have its portals up and running, its information systems up and running, and will have cleared through the qualified health plans by October. So I think that the piping will be there. I think that the problem, I'd like to think that's true. I think that the big problem initially is going to be matching people up with the products that are out there. I don't think that that the state of New Jersey has done a great job preparing to advertise, to educate consumers about their new opportunities. I don't think that the federal government is going to be devoting enough resources to funding navigators and community educators to get people connected. So I think the piping will be there. I think that getting people to the end of the pipe so that they can get their coverage is going to be a huge lift. And then, as everybody has said, for the next 10 years, we'll try to get the kinks out of the system and start trying to rationalize the cost structure.
Governor, still cautiously?
I'd raise one question and make another observation. This is being administered by the Department of Banking and Insurance. I'm not sure that's the ideal place to go to administer this program as opposed to the health people. And the other observation that we haven't mentioned, which is kind of interesting, and could change the outcome of our preparedness, is undocumented immigrants. That to the degree that the immigration bill is now being considered in Washington, that might change the status. That might provide an opportunity for those folks to be covered, and therefore reducing the number of uninsured people as well. I think that could be a significant change, and hopefully the immigration bill will make that modification.
I think there'll still be a role for charity care with regard to the estimated 1,000 undocumented workers. But Dr. Conway, last word for our panel?
Well, I'm always optimistic. I look forward to a day in this state, this nation, where people who need insurance can get it, and that they'll have a physician that they can see and a hospital healthcare system, hospital system that they can use for the maintenance of their health. So things will be fine.
Okay then, well then, please join me in thanking the panel for this.